It's too loud. Do you have volume control? I'm so volume challenged. I can't speak quietly enough for this to not be hurtful. Very difficult for me. Okay. Thank you so much for coming. I'm Jennifer Singh. Surprisingly, I'm on medicine faculty here, which will come as a shock to you because you probably don't see me very much. I'm based over in Feist-Weiler, and I see lots and lots of familiar faces, but for those of you who don't know me, I'll do the brief version. I went to medical school here, did a med-peds training here. I was briefly the med-peds program director, and Lauren Beal and Sarwat Umar are some of my claims to fame of fabulous people that I had the privilege of working with during that time. And then I had a 10-year period where I mostly homeschooled my children as a little sociology experiment, but also continued to teach here at the Med Center. During this time, I had a big aha moment. My dad was diagnosed with 2 malignancies within about a 3-year period. So, you know, many of us get very open-minded when someone we know and love gets sick. Has that ever happened to you? You think things sound wacky until someone you love is ill, and then you get very open-minded. So I began to go into desperate daughter-doctor mode, determined that there was got to be something more we could do at home to help my dad's quality of life as he struggled with prostate CA and CLL. And I found myself in this tribe of incredible evidence-based clinicians who were practicing medicine just how we do, or the way I was taught, but with a much, much, much heavier emphasis on empowering the patient to take care of themselves every day at home, too. We all know that when they come in and we write the prescriptions, there's really only so much we can do with that, right? They can go home and in a weekend undo everything you did during a 5-day hospitalization. Lifestyle medicine emphasizes empowering the patient to do what they can between the times when they come in to see us. This is a bait and switch. You thought you were here to hear about Partners in Wellness, but if I've got you in my grasp, you know I have to talk about lifestyle medicine. But I am going to talk about Partners in Wellness. I'm going to tell you how these two are going to hopefully work together. So brief agenda, I'm going to introduce to you Partners in Wellness. Many of you may not have ever heard of it. We're going to talk about what it is, where it is, and what it can do for you and your patients right now. Then I am going to tell you a little bit about some of the key scientific evidence behind this emerging field of lifestyle medicine and how it can help you, affect you, or maybe even draw you in as a new emphasis in your own practice. I would like to tell you a little bit how other people are doing lifestyle medicine because, newsflash, the current model of us running up and down the hall seeing one patient at a time doesn't work to actually do lifestyle medicine. We'll talk more about that as we go on. And again, I'll talk about how you can utilize Partners in Wellness now, in the immediate future, and in the distant future. So just a little bit of history about Partners in Wellness if you haven't heard of it or utilized it before. Partners in Wellness started as a complete charity outreach, essentially, clinic. It was a grant-funded clinic for our patients who were uninsured and didn't work and didn't have enough money to pay for screening services. So these were our patients who, you know, we kind of consider to be the working poor. Prior to Medicaid reconstruction, we had a lot of patients who could not afford basic screening services. So a group of practitioners in our wonderful institution got together and started a grant-funded clinic where our patients could come and get mammography, pap and pelvic, and prostate screening exams. They got all this free. So if you've been here long enough, you've probably been here long enough to know that Partners in Wellness has been located in how many different places on this campus? 7? It's been everywhere. It used to be in the old medicine clinic, then it was over in family practice building, so it's been located everywhere. Now, however, it's grown to the point that have a brick and mortar building over on Fairfield and offering even more services. We see about 575 patients every month for a variety of services that we provide. And we have a great return rate on our patients who come there. If you've ever sent a patient to Partners in Wellness, we probably keep them. And I'll tell you why. Because getting services at Partners in Wellness is so easy, it's like pulling into Circle K. It's not park, take the shuttle, get to the clinic, check in, walk, sit, wait, move to the room, wait some more. It's just like running in, grab a drink, grab a bottle of water, and they run back out. So we have a very high retention rate at Partners in Wellness. One of our flagship claims to fame is our little tiny fleet of mobile health vans. We actually have 2 mobile health vans that are equipped with mammography, and we service 22 parishes all over North Louisiana in hard-to-reach places for women who don't have access to mammography. So, if you've got a patient who lives out in Bunkie and she hasn't had a mammogram, she might know that the second Tuesday of every month at the health unit, the Partners in Wellness mammography van is going to be parked there, and she can get a mammography there. And this is mostly grant-funded with some state funding, too. So you may have seen us down at the corner of Olive and Fairfield. We're right next to Susan G. Komen and Vital Care Prescription, which we don't utilize. But again, our current services are 3D mammography. We have a breast ultrasound machine. So if a woman comes and has an abnormal mammography, she can get her ultrasound right there in our clinic. We do have an on-site breast radiologist. We provide PAPs and pelvics, specifically for women over 45. We actually don't do contraception, so the younger than 45 crowd tends to do better in OBGYN. We provide bone density and DEXA scans for your patients who qualify for bone density scanning, prostates and PSAs. We currently do FOBT for colorectal, but we're upgrading that soon, as I'll cover that. And we have a lung screening program, and many of you send your patients to Partners in Wellness for lung screening, and I thank you so much for that. Our lung screening program is growing, and we are constantly trying to grow it more. Anybody sent patients for lung screening? Yeah? Excellent. Thank you so much. What are we going to do over there now? Well, first we're expanding. We've just been given permission to expand into the adjacent Susan Komen office, so we're getting a much bigger clinic building. And the reason that should matter to you is that hopefully in a few months, you're going to be able to have a resident elective in lifestyle medicine at the Partners in Wellness facility. We're also expanding our screening services. We're going to start doing FIT for colorectal screening. We are getting the services of a breast surgeon in our clinic so that we will be able to offer a full-service, one-stop shop diagnostic breast experience. And we're going to begin offering Hep C screening. Then the fun part, we're going to start adding some preventive and lifestyle medicine services. Because screening is great. We have them come in one day a year, and we tell them, yes, you have cancer, or no, you do not. Wouldn't it be cool if we also educated them on what they can do the other 364 days of the year to keep from having a positive screening when they come in? What if we put an equal amount of emphasis on that period of time between screenings? And I'll talk to you a little more about survivorship services. So just a quick review about the FOBT to the FIT test upgrade. In the 2018 American Cancer Society recommendations for colorectal screening, adults age 45 and older now can undergo colorectal screening with FOBT, FIT, or a visual exam, of course, with colonoscopy. Patients don't always want to have a colonoscopy. So we can offer them now FOBT or, even better, FIT testing, which is the fecal immunochemical test, which is specific for human hemoglobin and is an upgrade from FOBT. So we will be giving FIT tests in Partners in Wellness, and then we'll talk a little bit more in a second about how to even get them to show up for a FIT test. Think about this. If you write a prescription or if you refer a patient to Partners in Wellness and you say, guess what? If you drive to this little clinic on Fairfield, they're going to give you a card to take home. Do you think your patient's going to be excited about that, driving all the way over there to pick up that card? No. We're going to bundle that with other services in a one-stop shop sort of arrival to increase adherence, hopefully. So depending on patient preference, those patients who don't want a colonoscopy can undergo FIT testing for their colorectal screening. We're getting, in just a few weeks, I'm very excited about this, a breast surgeon. If your mom or your sister or you yourself was found on screening mammogram to have an abnormality, think of this scenario. You get a phone call, your mammogram is abnormal. You need to come back in and get a diagnostic mammogram. On return to diagnostic mammogram, you're told, yes, it's still abnormal. You're going to need to come back and get an ultrasound. You come back for another trip and get an ultrasound. This looks a little concerning. You're going to need to see a breast surgeon. So you get another appointment, and that appointment might be 10 days out or so, and come back to see a breast surgeon. There's a possibility, if you're in a facility that has the correct equipment, that you could actually get your biopsy that day by the breast surgeon. But on our campus, there's a lot of problem with that happening right now. With the addition of a breast surgeon at Partners in Wellness, a female can have an abnormal mammogram and in the same day return to clinic on the afternoon, get a diagnostic, an ultrasound, get examined by a breast surgeon, and get a biopsy right in clinic in one day. Fantastic standard of care. It's what's happening in most of the rest of the private world, and we're thrilled to be able to offer that sort of convenience to our patients. So one-day diagnostic experience, it's what we would want for ourselves or for our family member, really. Hep C screening. So the CDC now says that any adult born between 45 and 65 should be tested once for Hep C, regardless of their risk factors. So you can think about your patient population. That's the vast majority of who we see. So Hep C annual report from the Louisiana Office of Public Health, there's 79,000 cases that are actually registered in Louisiana, but likely an enormous pool of undiagnosed and asymptomatic. So at Partners in Wellness, we're almost ready to offer the complete workup package, meaning that when your patients come to us for something else, maybe their pap and their pelvic, while they're there, we can bundle their screenings and go, hey, let me hit you with a Hep C antibody screening real quick, because you fall into the appropriate category for that. If that's positive, they can return to our clinic and get all of their confirmatory and pre-testing workup in one easy-to-access spot at Partners in Wellness on Fairfield. So the rapid testing can be done. We actually now also have a fibroscan or elastography machine. So when the patient returns as a confirmed Hep C, they can have everything done in one stop. So do you see a theme here? The one-stop shop for whatever's wrong with you, right? An under-roof, easy access approach for our patients who are challenged with access. So again, currently, here's what we're doing now. Mammogram, pap and pelvic, prostate, bone density, lung cancer, colon fit testing, Hep C, and one-stop mammogram and breast clinic are coming soon. But we would like to expand to not just a preventive and screening clinic, but a full lifestyle medicine and prevention clinic. So to tell you a little more about that, I'm going to branch a little bit into lifestyle medicine and what it is. So lifestyle medicine is actually an emerging subspecialty of medicine. It sounds like I made it up. People are like, what do you do? I'm like, no, it's just lifestyle. It's just medicine. And so, you know, you've heard the apple a day will keep the doctor away, and it will if you throw it hard enough. I always thought that was funny. If it's thrown hard enough, it'll keep anybody away. So what is lifestyle medicine? It is the evidence-based, heavy application of common sense. So evidence-based is the critical terminology here. And it is the practice of helping individuals and families adopt and sustain behaviors. So just as much as it is nutritional medicine, mental health medicine, physical activity medicine, it's actually behavioral medicine. Think about it a minute. How hard is it to help someone change their behavior? How hard is it for you to change your behavior? And you have resources, you have a car, you have a credit card, you have easy access to medicine. Think how hard it is to change a patient's behavior. It is extremely complex. The reasons that we do things and the influences on our behavior are extremely complex. Why is it worth it? Why in the world is it worth it to even dig in and help a patient change behavior? Let's talk about that a little bit. I want to introduce you to a professional organization called the American College of Lifestyle Medicine. This is an AMA-recognized association that has several tenets of what does ACLM or what do we really have the strongest evidence for that we should be stressing. Tobacco cessation is number one. I think we all have, there's no debate that we have plenty of evidence to stress tobacco cessation, right? A whole food, plant-strong diet that is mostly unprocessed and that has adequate plant-sourced food in it. Moderate exercise, stress, non-drug, and sleep are also part of the equation. And the studies show that not only is this really the most powerful medicine that we've got to prevent the chronic diseases that we see, but it also is pretty effective many times at actually treating in conjunction with what we're prescribing, and even sometimes reversing. So we're talking about taking a patient and helping them become a non-patient, helping them actually get well. So the American College of Lifestyle Medicine's past president, Dr. David Katz, has a quote that I like. It kind of sums up the paradigm of lifestyle medicine. It has the potential to prevent up to 80% of chronic disease, and we'll talk about where that number comes from in just a minute. It is expensive. It can even be cost-saving in the big picture. It's free of side effects, except good ones. It's safe and appropriate for people of all ages. It is quite simply the best medicine we've got. In addition to a college, I want to introduce you to the American Board of Lifestyle Medicine. There's also an International Board of Lifestyle Medicine. There is a board exam that you can take as an add-on board to whatever board certification you already hold. And it's not necessary, honestly, to practice lifestyle medicine, but it is easily attainable through some online and some live attended things. Their goals are to set a common standard in language for lifestyle medicine, and then talking about evidence-based, Dr. Sewell and I were just emphasizing the words evidence-based. The other thing that I love about this board is that it's very dedicated to differentiating between those evidence-based lifestyle practitioners and those non-evidence-based practitioners who are calling themselves lifestyle practitioners. And with the rise of the industry surrounding health and all of the non-credentialed people that can be found online now, I really, that's why I belong to this group, basically. And the other thing that they're doing that's very useful is lobbying and making a presence for us legally to be reimbursed for these activities, which our current system, as you know, is poor at doing, at making this lucrative. So I don't have to tell you that the major causes of death in the United States are very similar to what they have been for the past decade or so. Heart disease, cancer, and chronic lower respiratory disease are still topping the charts for the CDC causes of death. Strokes, accidents, which, we can do a whole lot about that, Alzheimer's, diabetes, and flu, and this really hasn't changed all that much. Back in the 90s, a group of scientists did a sentinel study where they asked the question, what are the actual causes of death? We know that this is the end point, but what are the typical behaviors that lead up to these causes of death? Heart disease doesn't just happen in a vacuum, right? It happens over years. There are years of behaviors and genetic factors that lead up to that heart death or that cardiac death. So they asked the question, what are the underlying behaviors and the underlying risk factors to all of these causes of death? And in that study, which they boldly entitled The Actual Causes of Death, they were able to drill down to a not very long list of things that actually underpined the top causes of death in the United States. And those were tobacco, obviously, poor diet, physical inactivity, alcohol consumption, microbial agents, we won't worry about that right now, toxins and MVAs and firearms. But if we just look at the top two, tobacco and nutrition, I have made it my career to focus on these two things in our patient population. And I personally think it's the only chance we have of pushing Louisiana out of 49th position in overall health outcomes is by focusing on these two things, tobacco and nutrition. It's interesting, I have so many colleagues in other parts of the country who are practicing lifestyle medicine, and they're pretty shocked that we're still coping with tobacco as a major addiction here in our patient population. There are areas where it's not as much of a problem as it is here. But as you know, we still deal with this daily in our patients. And what they found was that about 80% of the chronic disease deaths in the United States could be attributed to those few risk factors. In another study, about 30,000 subjects were studied to determine what were the magical behaviors then. What is the antidote to this problem of death due to chronic disease? And they found that there were essentially 4 magical healthy behaviors, and none of these will come as a shock to you at all. Never having smoked, or at least having quit for at least 15 years. A dietary principle that emphasized unprocessed fruits, vegetables, and whole grains and legumes with lowish meat consumption according to the standard American diet, performing about 150 minutes per week of physical activity, and having a healthy BMI. Easy, right? What do you think the average percentage of Americans is who have all 4? Any guesses? What'd you say, Dr. Sewell? It's 4% of Americans. have all four. The encouraging thing, however, is that incredible incremental improvements and outcomes were seen with every single factor that a patient could get. So for instance, it matters, it's worth it to just get one. It matters even more to help them get two, or even in our own selves to get two. If you can get three or all four, you have almost, this is pretty simplistic, inoculated yourself from an 80% chance of having the top three chronic diseases. So adherence to these four, they were able to predict in their cohort of about 30,000 that 93% of diabetes cases were absent in those having all four. 81% of heart attacks, 50% of strokes, and 36% of all cancers by having the four magical lifestyle factors. But again, improvement was seen with every single factor that was acquired. Even one increased the time in a subject's life where they were free from the four major chronic conditions. And everyone that was gained over that accrued even more health benefit. So their comment was that our results and those of others emphasize the importance and the urgency of vigorous attention to lifestyle behaviors as a major form of medicine, actual medicine. Standard American diet, anybody who's been around me knows I love to talk about the standard American diet. What's wrong with the standard American diet? There's really nothing right with it. We'll flip it. What's right with it? Not much. 23% of the calories in the standard American diet come from grain, which could be a good thing, except what do you think happens to the grain in the standard American diet? Any guesses? What do we do to the grain? We process it, right. Everything beneficial about the grain, the bran, the protein, the fat that's even in naturally occurring grains is completely removed, and it's processed into a white powder, which looks remarkably like cocaine. 8% of our caloric intake comes from fruit and vegetables, which is dismally low, and that count includes French fries. So, dismally low intake of plant-based food source in the American diet, and as you can see with the grains so far, everything that we've consumed in grain is pretty much processed. 17% of the daily caloric intake of Americans comes from added sugars. So these are sugars that have been added to, again, processed factory-made foods, many of it now very slyly and smartly packaged to look like health food. And you've tasted the healthy kid granola bars, or the healthy kid this bar, or the healthy adult this bar. Just flip it over and see what's in it. And it likely has a significant degree of added sugar if it tastes sweet. 23% of daily calories come from added fat. Again, this is usually processed fats that have been added in a factory in a processed food. 25% of the calories come from meat, which, although it does provide protein, in the plate that looks like this, it becomes even more detrimental because it's taking up room that could be taken up by fiber and phytochemical giving plant matter, which it's not. So 3% of our calories come from beans, which is also very sadly low because bean and legume consumption is a marker of longevity in all of the longest lived populations on Earth. We know that they are full of fiber, full of protein, and again are a marker for health. We all worry about the BMI. So obesity, of course, no one has to tell you about the obesity epidemic, and that's sort of the bouncing red ball that we've all been looking at for so many years with the diet. Anything to decrease the BMI, anything. And most of us in here have done the cabbage diet or the Slim Fast or whatever. There's a lot of ways to decrease the BMI. But nutritional science, more and more over the past few years, has shown us that it's not just the weight and the cardiac risk factors. It is the components of the food, aside from the calories, the fiber, the antioxidants, the phytochemicals, the phytoestrogens, all of these different nutrients that are in food. So the diet is not just making us obese, but there are nutritional studies to link diet to almost every condition that we see that's chronic. So constipation, ulcerative colitis and Crohn's, there's a lot of hypothesis about nutritional prevention or nutritional underpinning in populations who don't have these diseases. CNS diseases like Alzheimer's, migraines, and multiple sclerosis. And of course, cancers, especially prostate, breast, and colon, have strong nutritional links in the literature. So essentially, a standard American diet is perfectly positioned to provide an inflammatory state. It causes oxidative stress. And now, even with the studies of epigenetics, there are many good studies that are showing that what we eat can actually activate or deactivate certain parts of our genetic code. My daughter picked this out for me. So you can imagine what it's like growing up as a tween and a kid in a house with a gastroenterologist and a nutrition-based pediatrician person. So it's basically just been, just be quiet, eat your salad. We want to drive down Uri Drive and eat chicken like the other kids. We did plenty of that too. They're not abused. I want to talk briefly about what lifestyle medicine can do for 3 conditions: coronary disease, diabetes, and cancer specifically. So some of you may have heard of Dr. Dean Ornish. Have you heard of Dr. Ornish? He's sort of a celeb MD, right? So Dr. Ornish is quite a media guy. However, he's done some pretty intriguing and at least thought-provoking things in the world of cardiology. Dr. Ornish spent most of his career and life asking the question, can you alter a human's diet to the point that their body can, to some degree, correct its own atherosclerosis inside of the coronary vasculature? And although this has been shown in one study where patients were hospitalized and essentially imprisoned, where their diet was completely controlled, well, sure, if you lock me up and don't let me go to the grocery store, you can do a lot of interesting things with my diet. But he wanted to know, can ambulatory patients who had free will out in the world achieve health changes to the point that they could reverse or stop coronary disease? So in his study entitled the Intensive Lifestyle Change Study, this was an RCT where the intervention group underwent an extremely low-fat, plant-based diet with no volume restriction. They ate all they wanted. They meditated. They did a walking program, and most of them got some sort of stress-reducing psychotherapy. So you can see that in the beginning, everybody in the intervention and the control group had a mean diameter of stenosis of about 40. And then a year into the program, on repeat left heart cath, the intervention groups had dropped to 38, and the regular care group had increased slightly to 42. And then interestingly, I guess his subjects sort of have a cult-like following because he had a pretty significant 5-year follow-up where he was still able to get people to submit to a left heart cath after 5 years. And you can see after 5 years that the treatment group had dropped their stenosis down to 37%, where the control group had continued to advance on the standard diet up to 50%. So he petitioned Medicare with these and many other studies and was actually able to get Medicare to reimburse for the Ornish program for reversing heart disease. They determined that it does meet the intensive cardiac rehab criteria. So we actually have an Ornish, and of course it's branded. We don't have it here. We have it in Shreveport. A competitor of ours has an Ornish program. But if anyone is interested, I would love to see us have our own cardiac reversal or intensive cardiac program here on our campus. There's really no reason that we couldn't do that and probably publish some great studies coming from that. Another gentleman, Dr. Caldwell Esselstyn, was similarly passionate about dietary intervention with coronary artery disease, and in several patients has documented pre and post studies like the one you see before you, which even he admits is the most extreme pre and post he's ever seen. So this is the ultimate cherry picking. This is like that one person who had this extreme pre and post. But it is an incredible testament to what the body is capable of if the dietary intervention is adhered to. So you can see on the left the tortuous nature of the vessel in the left heart cath, and then several years after being on an extremely low-fat plant-based diet, you can see that that's without physical intervention. And that wasn't the only one. He's actually got stacks of pre and post patients who he's counseled, put them into an intensive lifestyle program, and been able to stabilize their coronary disease. Now, is this scalable to the general population? I don't know. Maybe not. But what we learned from the Mokdad study earlier about those 4 major habits is that to turn the Titanic of population health, we don't need an entire population of people doing everything perfectly. We need an entire population of people doing things better on a big scale than they are right now to overall affect population health outcomes. Many of you have heard about the Diabetes Prevention Program, and in the New England Journal article, Reduction in the Incidence of Type 2, which was a randomized controlled trial, the results of this study helped us know that starting pre-diabetic people on metformin could reduce diabetes by about 31%. But what you may not know is that there was another arm of that study, which was simply an intensive lifestyle change, boot camp type experience, and it was actually more effective than the metformin arm. So maybe we could offer both to our patients. In another diabetes intervention, the question was asked, could reducing the fat in the diet and increasing the fiber while liberalizing carbs in a diabetic, complex carbs, no processed carbs, could that possibly be an effective and easy to adhere to intervention for diabetics? And the control group was placed on a conventional ADA diet. The intervention group was given some pretty simple instructions. Decrease your meat, don't eat liquid fat, avoid dairy, and only eat brown carbs. That's it, only brown carbs, but no counting of anything. And interestingly, although both programs only had modest improvement, the carb liberal program did outperform the other one. Simply more reinforcement and evidence that unprocessed, maybe not so tightly calorie controlled, plant-rich, meat-moderate approaches could lead to better health outcomes. Talking about moving on to cancer, all of the major cancer organizations readily advertise and recommend now the link between obesity and cancer. So the American Cancer Society says the risk factors that are associated with a Western lifestyle have been shown to increase colorectal risk, not just smoking, but obesity, high consumption of alcohol, red and processed meat, and low consumption of fruits, vegetables, fiber, and calcium, and physical inactivity. This is lifestyle medicine. ACS is telling us this is how we prevent cancer. Another organization, the American Institute for Cancer Research, similar, has amassed quite a body of evidence that increasingly it is unlikely that specific foods have magical properties. It's not one specific food or nutrients or any other components of foods themselves. It is a collection, a dietary approach. Rather, different patterns of diet and physical activity combine to create a metabolic state that is more or less conducive to cancer. The World Health Organization recognizes that up to half of all cancer cases are preventable with lifestyle intervention. Tobacco is, of course, the single greatest risk factor, but evidence continues to emerge all the time between weight and many other types of cancer: esophagus, rectum, breast, endometrial, kidney. Again, same song. Diets high in fruits and vegetables may have an independent protective factor regardless of the patient's weight. Regular physical activity, maintaining a healthy body weight, considerably reduce cancer risk. And even the American Society of Clinical Oncology, obesity is associated with worsened cancer prognosis. Negatively affects the therapies that we do give to the patients. The response is different and less beneficial in those who are obese. And it may raise the risk, of course, of secondary chronic problems. Sometimes we can help them get through the cancer, and then they have an MI a year later because of the underlying metabolic state. Several trials, specifically in survivors, which is one of the things we've been emphasizing at Weiss-Weiler, several trials demonstrate that reducing calorie intake, improving dietary quality, and getting them moving, simple, common sense, the intensive application of common sense, has a number of benefits. Studies and survivors show improved quality of life, less fatigue, better body image, lower incidence of comorbidities like heart disease and diabetes, better fitness levels, and favorable changes in their biomarkers that are linked to cancer risk and prognosis. Just from the application of common sense, we can decrease the markers of increased risk. To sum it up, lifestyle medicine's focus is, again, the intensive application of evidence-based practices that we know affect health outcomes. Tobacco cessation, nutrition, and simple movement, with secondary emphasis on sleep, stress, and mental health. I think for our patients, if we can hit those three right there, we would be doing them an incredible favor on those three right there. So simple. We just get them to put down the cigarette and eat broccoli. Super. Easy peasy, right? So I'm not naive enough to think that this is easy or that it can happen in our current medical paradigm. With us running up and down the hall, seeing one patient at a time, in a hurry, always with more patients, always limited on time, behavior change is extremely difficult. We have to be creative, look at what other people are doing, role model some new vehicles of healthcare delivery. And again, I've mentioned this a second ago, how do we change behavior? It's incredibly complex. For procedures, we put together teams of highly trained specialists because those procedures are complex. They're complex. There's so many factors. It takes a team. Behavior change also takes a team if it's to happen on a population scale. So we are time limited. We don't really have the skills and the knowledge to help our patients. We're not behavioralists. We're doctors, right? So how are we supposed to spend 5 to 10 minutes with a patient and actually change their behavior, which you know from trying to change your own, how complex and challenging that can be. We lack support for ourselves and our own health and our own behavior change programs. We lack a team approach. We lack appropriate follow-up touches. The more contacts a patient gets, the more likely they are to maintain a behavior change. That touch can be face-to-face. It can be on the phone. It can be an email or a text, depending what population you are in. But the more touches, the more likely they are to actually maintain a behavior change. Studies show that the more times we touch them digitally, on the phone or in person, the more likely they are to maintain behavior change. We got to think outside the box. We have to think of some novel vehicles to deliver lifestyle medicine. And the three that I would like to point out to you are a dedicated lifestyle medicine center or clinic where we as the doctor in the hall is not trying to deliver the exercise, the nutrition, the smoking cessation. We can't do it all in our current model. A shared medical appointment model and a bundled care visit. I'm just going to break these down real quick. So all the cool kids are doing it. A dedicated lifestyle medicine or integrated center. Cleveland Clinic has an integrative and lifestyle medicine section. Harvard has their Institute of Lifestyle Medicine. Midland Health, Texas, which is pretty famous for their pioneering work in lifestyle medicine. Duke has an integrative training program and an integrative center. MD Anderson, Mayo Clinic. So we should do that here. We should have a section of lifestyle medicine and integrative medicine, starting with a small clinic. So I envision this as myself and an additional MD, Dr. Rupa Mahadevan, raise your hand, has joined our faculty. She's an integrative physician who's integrative trained and has recently moved down. And the way these would work would be an initial one-on-one visit with a physician who would determine the care plan. And then that patient would enter a system where everything, the team, was all under one roof. They could follow up with SMAs, which are shared medical appointments. And for those of you who are wondering, how in the world are these paid for? These visits are all billable with standard E&M codes. A resident elective is coming soon. As soon as we get our extension space, Rupa and I will be precepting a resident elective where we will actually be seeing patients in these one-on-one intake visits with residents and getting patients into the lifestyle medicine approach. So again, the MD would perform the intake visit, multiple disciplines under one roof, that team approach. The patient doesn't have to drive to 4 different appointments that are spaced out by 6 months. The nutritionist is there, the tobacco cessation person is there, a fitness specialist is there, either part-time or full-time, behavioralists, and there is a lot of collaboration on the care plan for the patient. Another novel vehicle of care is the shared medical appointment. So we actually started a pilot program of shared medical appointments over in Feisweiler last summer. A shared medical appointment, if you haven't heard of this or seen it, imagine a support group meets a doctor visit and your insurance pays for it. That's pretty much what it is. These can be structured and run in a way that they are billable by the physician with regular E&M codes when they're structured in a way that all the E&M bullets are delivered and met appropriately. Other professionals can be brought in to provide extra education during the visit. And the amount of support that the patients give each other is really amazing. Patients sign a consent. They're perfectly fine with telling their medical history in front of a group of people. So imagine you're sitting there and they're sitting around you and you go around the circle and you take the HPI in front of all the other patients. It's really interesting. And it's really fun when they start turning to each other and going, oh yeah, that happened to me. The support and that they provide each other is interesting. So the group support session meets the doctor visits. We have been doing these in a setting where they have a shared diagnosis. Our pilot program was breast cancer survivors. It is manned by a provider, which is either a mid-level like an PA or a nurse practitioner or an MD. That's how they remain financially lucrative. Someone has to bill. So they are run by a provider. There must be at least one, if not two, assistants who sort of run interference and run the remainder of the visit so that the MD or the provider can conduct the appropriate stuff to bill. And again, these are billed with regular E&M codes. The studies all show in the literature very high patient satisfaction is kind of unanimously one of the recurring themes. Provider satisfaction is also very high. Improved outcomes in some chronic disease management. Diabetes really has probably been studied more than any other, and the evidence can be good in many studies that delivering this self-management in groups like this is effective for diabetes outcomes. There's been a lot of research in CHF and shared medical appointments. There's really no clear-cut evidence yet that it actually improves outcomes. It does appear in many studies to decrease utilization or bouncing back from recent discharge. It can prolong the time till next hospitalization. So our survivorship program was a pilot program, as I mentioned, of breast cancer survivors. We had a cohort of 9. They attended 4 visits that were spaced out between 4 and 6 weeks, and each visit was conducted in a group. It was run by myself. I have a nurse who is an assistant, and I usually had a medical student running around also. And they received multiple services at each visit. So a theme of lifestyle medicine is they get a lot of value for showing up. So imagine if you're a breast cancer survivor and you're having trouble with your lymphedema, and you've noticed that your neuropathy in your right foot is causing you to stumble recently, and you've never even heard of the fact that what you eat or your BMI could possibly influence your chance of recurrence. So you're able to come to a 90-minute or 2-hour visit. You get attention from a dietitian, a screening by physical therapy who tells you that they can help you with your neuropathy and instability. The lymphedema team is present to help you with your lymphedema sleeve. And you get a group support program with other patients. So we were able to conduct this with this cohort. And again, the focus was on nutrition, physical activity, mental health, and we had several smokers who were still in that cohort. So we were able to bring in a tobacco cessation specialist and actually get them some counseling in their visit. And we have cohorts now of head and neck survivors and colorectal survivors underway. We're having a shared medical appointment once to twice a month. So if anybody would like to observe a shared medical appointment, let me know. You can come over and watch anytime. Our next priority is a much more robust tobacco cessation clinic here on campus. As you know, we currently have services here on campus, but unfortunately we only have a trained specialist on campus a couple of times a month. So we are looking to have a provider living in Partners in Wellness so we can provide ongoing tobacco cessation for our smokers. We'd love to model this after Ochsner's program. They have 22 well-running clinics down in South Louisiana, And did you know that patients in Louisiana who are receiving smoking cessation care don't actually have to be billed for any of it because of the huge tobacco trust settlement that took place in Louisiana? And because I really do believe that fruits and vegetables cure everything, even addiction to nicotine, I had to show you this particular article. A longitudinal evaluation showed that smokers who ate fruits and vegetables were 3 times more likely than those in the lowest quartile of consumption to be abstinent. So broccoli really does fix everything. There's really nothing kale can't do. In the future, Dr. Mahadevan is going to bring pediatric obesity treatment to our area. This is perhaps the great frontier that is needed here in Shreveport. And there's, I have a feeling, going to be so much demand that we're very quickly going to have to grow and figure out how to accommodate our referrals that are literally just waiting for her to begin this service. So this will be conducted in shared medical scenarios also at Partners in Wellness. So she's here. She has done this in her previous employment, has started and ran a pediatric obesity clinic, and she's also going to be participating in the Survivorship program. Finally, one last novel vehicle is the bundled screening visit. So previous studies have shown that women will come in for a mammogram much more readily than they will for colorectal screening. So Dr. Davis and Dr. Arnold have done some studies in rural North Louisiana here showing that if you can get a woman in for her mammogram, you're much more likely to get her to go through colorectal screening also. And in some other areas, mammogram was grouped with PAP, pelvic, and colonoscopy. And it, of course, showed that when a woman comes in for her female care and you bundle multiple services in, you accomplish greater rates of screening if you bundle this care and make it all easy. Who wouldn't show up for one 3-hour visit once a year and have everything done? Everything. Your colonoscopy or your fit testing, your PAP and your pelvic, your mammogram, or your prostate counseling and an exam, everything in one day, and you're done. So just a brief schematic. Currently offered, we have our 2 vans, going to offer in new ways. We can't do it the same old paradigm. Has to be some novel, out-of-the-box thinking in order to make this sort of medicine happen. And hopefully what we're building is a Partners in Wellness, not just a screening clinic, but a prevention, lifestyle medicine, and integrative medicine clinic. So here's what we're currently offering. Just put it in the next few weeks, we'll have breast surgeon services, fit testing, and Hep C screening. And we will let you know in a few months when we are ready for your referrals for lifestyle medicine services, for tobacco cessation, obesity, diabetes, cardiac disease, pediatric obesity, and again, a fellow and resident rotation. So again, what this means for you is a system through which we can learn to put patients in that same team approach that takes place for complex and complicated procedures, a team of highly trained people approaching behavior change with the same emphasis that we do the other things that we do in medicine. A system that emphasizes lifestyle for motivated patients and provides evidence-based services that will improve patient outcomes. I think we've been through all of that. Any questions? No? Thank you. Good.
So first of all, how do you refer patients?
We can be referred to in EPIC. And many of you have done this with lung cancer screening, right? You can refer to Partners in Wellness. I would encourage you to refer any of your patients who need a mammogram to Partners in Wellness, bone density scanning to Partners in Wellness. It's an EPIC referral. Thank you for asking that. Thank you.
So I have a particular interest in a heart failure population. Do you in fact fit into the model you have? And probably not maybe already proven. Now we have a couple with that. On focus, root visits, all the other things. Are in the lower. But in the lower heart failure risk, how do you see that being
basic curriculum, or we're going to cover this and this meeting, this and this meeting. What we're still struggling with, and this is what everyone in shared medical appointment research is struggling with, what's the appropriate dosage? How many times, how frequently, how long can you keep them coming, and does that change based on socioeconomic status? And there's a resounding yes for that. It does. Patients who have resources and high literacy will come, they'll come once a week for 8 weeks if you want them to. Patients who have a difficult time getting here, you have a hard time even helping them get here for 4 visits spaced out over 6 months.
I know that Dr. Dominic is working hard, particularly with advanced practitioners, to try to develop that model.
Right.
I have a question. I think dose is a huge issue about how often can we, how long, what's the duration of this if it's monthly? Is there any evidence about phone calls or texts between visits and how often, what's the dose of that?
Now, I don't know the numbers. You might know that more than I do.
Well,
But I
I'll
do know
put-
that even phone follow-up helps adherence and behavior change. That it
It's another
doesn't
touch
have
point, yeah.
any other touch points. And so there's a lot of research in the digital field, you know, with, in fact, a whole new little nomenclature has popped up, the digital therapeutic, which is the boot camp over your phone, basically.
But the challenge is, and I guess this is different with different people, how much dose is supportive and helps you sustain the behavior? And then when do you say, lady, quit calling me?
Yes, yes. I don't know the answer to that yet, but we're working on it, especially planning to do some focus groups in our patients to find out from them, what is the percentage of our patients who would watch a YouTube channel? What's the percentage of our patients who would get a text message and find that helpful? Do they have a phone? Do they not have a phone? You know, obviously there's a wide variety.
To the point that you raise, access is different. We know from many of the other studies of underserved populations in trying to bring foods, you know, what is essentially a desert, what is commonly used. You say the food is inexpensive and free, but it's not. In fact, access to the foods that you're talking about can be incredibly expensive. How do you find out? How do you take what you're talking about in a digital world and make it available